I'm pleased to welcome tonight Dr. Rocco Chiappini. Dr. Chiappini is the Director of Physical Medicine and Rehabilitation and the Medical Director of the Specialty Hospital at Crotched Mountain Rehabilitation Center in Greenfield, New Hampshire. As a physiatrist, he provides inpatient and outpatient care to individuals with spinal cord injury, brain injury, and other neurological conditions. Dr. Chiappini is a graduate of the Medical College of Virginia and did his residency training in physical medicine and rehabilitation at Johns Hopkins Medical Center. Dr. Chiappini is a 1996 recipient of the Arthur Stephens Award from Johns Hopkins University and was named Top Doctor in Physiatry by New Hampshire Magazine in 2003. He is also a member of the Board of Directors of the Brain Injury Association of New Hampshire and is a certified brain injury specialist as recognized by the National Brain Injury Association. So please welcome Dr. Chiappini tonight to discuss spinal cord injury and obesity versus function.
All right. Well, it's really a pleasure to be here tonight. Thanks for the invitation, and thanks to Steve Williams and also Claudine Dejeau for all the help coordinating tonight's talk. It's really a pleasure to have this wonderful view. You know, I'm going to show you my view, which I think is beautiful too, but this is great, except maybe the Fenway Park part, since I'm a Yankee fan, but it is kind of nice to see the lights up. This is my view. I'm at Crotched Mountain, which is in southern New Hampshire, about halfway between Nashua and Keene, New Hampshire, if people are familiar with that. And Crotched Mountain is a facility that's been there in southern New Hampshire since the 1950s. We have a school for children with developmental disabilities at Crotched Mountain. We also have an inpatient rehabilitation unit that is multiple levels of care, from acute rehab through subacute and even skilled nursing care. So it's really a pleasure to be here to talk about this topic of obesity. I'm going to just show my my title slide again. The title is Obesity versus Function in Spinal Cord Injury, a Case Study. So I have, I think, a very interesting case to present. And what was really wonderful for me was the opportunity to really learn a lot through taking care of this patient. I feel that I had a very strong training in physical medicine and rehabilitation at Johns Hopkins, and we had really good training in spinal cord injury. So we learned about how to care for things like autonomic dysreflexia and neurogenic bowel and bladder, how to deal with people who are coping with their new injury, how to create successful transitions, et cetera, et cetera. We never learned one word about obesity and weight management and how this could be a very important aspect of a person's overall health and function and well-being. So I'm going to introduce you to my patient, CCA. She's a 51-year-old woman. She had a motor vehicle accident in February of 2002, and at that time she was taken to the ER up at Dartmouth and was diagnosed with a C6-7 incomplete spinal cord injury. She had surgical screw and fixation and was eventually transferred to Health South in April of '02. So this is her sitting on her bed at home after discharge from Health South in Concord, New Hampshire. At the time that this picture was taken, she was 5'7", 164 pounds, and had a bust size of 38C. And it's important to note that she was requiring a lot of Hoyer lift transfers when she returned home, and she requested from her insurance company a Hoyer transfer that had a scale so she could weigh herself, and this was denied. So by the fall of '02, she's already gained 11 pounds, and she's starting to get concerned about her weight. She watches her intake. She has not been advised at all about what to do about this problem. And, she does what she thinks she should do, is be active. She's doing home PT. She's doing her Stim Master bike and watching her weight. So she's hoping that that's going to be okay. Spring of '03, this is when I actually first met her as an outpatient in my practice. Her weight had gone up to 195, which was a 31-pound weight gain from the time of discharge. And she had gained 4 inches around her chest for a 42-inch bust. At that time, we talked about diet, and she told me she had tried Weight Watchers, and we talked about a thing called the Schwarzbein diet. I don't know if anyone's familiar with that, but it's a diet that's kind of low carb, higher protein, and kind of higher in healthier fats. So she tried that. That didn't really budge her weight. She continued with the home PT, the Stim Master bike. And so at that time, when I first met her, her functional status was that she could do slide board transfers from the wheelchair to either her bed or into a car. She could do wheelchair push-ups. She could side bend while sitting in her motorized chair and touch the base and then come back to an upright position. She was able to undress her upper body independently, and she could bathe in a shower chair with Min Assist. So by November of the same year, she had gone up to 210 pounds. She's gained 46 pounds. She's gained 6 inches across the chest. And at this point, she's now tried the Health Fast diet, which didn't work. 1,200 to 1,500 calorie diet without effect. But she did tell me in the office visit that, if I eat 800 calories a day, I can lose some weight. But how can you eat 800 calories a day? It was next to impossible for her to do that. So, at that time, she started aquatic therapy as an outpatient. And she's already beginning to lose function. She's having more difficulty with slide board transfers, mod assist of 2. She's having difficulty because she's feeling too top heavy and she's tippy and doesn't have enough trunk control. She can't do the wheelchair push-ups anymore at this point, and she's unable to do that side bend where she could touch her chair base and come back up. Basically, she's just becoming more. She's losing function. As we're seeing her. I was seeing her about every few months, and these were our check-ins. So by the spring, she had gained 62 pounds total. She's gone up 1 cup size with her bra. She had tried the South Beach diet without effect. And now she's beginning to really notice some shortness of breath when she's sitting up at 90 degrees. And sitting up at 90 degrees is really important for her because that's how she drives. And so as you saw in the picture there, in rural New Hampshire, you have to drive to get anywhere. And she's a very independent, motivated lady who wanted to independently drive herself where she needed to go each day. So driving was getting harder because she was getting out of breath. She was still doing her Stim Master bike. At this point, she's now unable to do slide board transfers at all. And she's dependent for dressing and showering. And she really had a pretty religious, tolerant, religious observation of a standing table. She'd get up every day multiple times during the day because she knew that that was good for her, but she really didn't have the ability to stand like that. So by the fall, she's now gained 58 pounds. This is 04. 8-inch increase across the chest. And she's eating a 1,000 calorie diet 5 days a week. This is kind of, she's, I think in the last slide, she had a total of 62-pound weight gain. So, whoops. So you can see she's kind of leveled off here with the 58-pound total. So the 1,000 calorie diet 5 days a week was somewhat effective, although very difficult and probably not fully healthy. But she's still having a lot of difficulty because of her size. She was very short of breath when sitting up at 90 degrees and had to keep the wheelchair seat to back angle at 110 to 120 to really feel comfortable. And at this point, we really looked at the possibility that, of doing something surgical for her, because we were getting nowhere really with diet and attempts at exercise. So we started looking into this idea of getting a gastric bypass or a banding procedure. So for people who are not familiar with the gastric bypass, it's called the Roux-en-Y gastric bypass. It's the most common obesity surgery done in the United States. And what is done is you disconnect the majority of the stomach, including all the way up to the duodenum. So right here, this part is detached. You make a little pouch for a stomach up here that attaches to the esophagus, so the food comes down this way, bypasses the stomach, goes down here, and then meets up with the intestines as it would normally. And then the stomach and the duodenum are attached in here so that digestive juices can get in and cause digestion. So this is a very effective surgery, not without its risks and complications, but it has, it's the most widely accepted surgery for people with obesity. The gastric banding has a similar concept, although you're really not detaching anything. You're putting a band around the stomach and creating this pouch. So you have a similar type of pouch, but the food would come down here, kind of get caught up in this pouch, and then slowly empty into the stomach. The idea behind both of these surgeries is that when a person eats, they're going to get full very quickly with this small gastric pouch. And by the way, the gastric banding is the primary type of obesity surgery done in Europe, as opposed to the Roux-en-Y, which is the American style. It's more preferred here. So, and both of them have been shown to reverse effects, to reverse kind of lipid profiles. So people that have very high cholesterol, high triglycerides, people with diabetes, hypertension, a lot of these have been shown to be reversed with both of these surgeries. So that's what we started looking into, and we mostly looked at Dartmouth as a place where this might be done, because we thought maybe a teaching hospital would be open to this idea with someone with spinal cord injury. So now it's December of '04, and she's got a total of 62-pound weight gain. Now she's not really fitting into her power chair anymore, and obviously that is affecting her function and her independence. And she's continuing to have the shortness of breath and needing the Hoyer transfers. By July of '05, she's having to stop when she's driving her car so she can recline her chair and breathe, and then she's after she catches her breath, she puts her chair back up to 90 and drives a little farther. It's very, very disabling for her. And she was denied for the lap band surgery. So the gastric bypass, they didn't even want to consider. They thought maybe a lap band, but she didn't meet the criteria by BMI, the body mass index. So I'm going to talk about BMI in a few minutes, but keep that in mind. She didn't meet the criteria. So we had to go back to the drawing board. So we pursued plastic surgery consultation for breast reduction and abdominoplasty. So abdominoplasty is basically liposuction. So that's what we looked at doing. We did find a surgeon who was willing to do this procedure, and we were, I was kind of surprised we were able to get the insurance company to agree in October. And by December, she had this surgery. So it was about a year of trying to find somebody who would do this for her. So in mid-January, I saw her for a follow-up after her surgery, and she had lost 25 pounds with the surgery and really started noticing improvements in her function. She found that it was easier to roll in bed. Slide board transfers were something that she was starting to try again. And she could tailor sit on the floor. So she could sit on the floor with one leg out and another leg crossed on top of it, which indicates a decrease in this top-heavy tippiness that she was feeling before. So she had some significant improvement in her trunk control and some function right away. By March, she was reporting no further shortness of breath when sitting at 90 degrees during driving or when using the stander. She was able to remove her own socks and shoes independently and could do her own upper body dressing. So needless to say, she was delighted. She felt like she had gotten her life back to some extent here. June of '06, she got a permobile standing wheelchair, which allowed her to stand when she was at work and also propel her chair in a standing position, things she couldn't have considered before. Breathing was not a problem during standing. By December '06, she was down to 198, and in November '08, this month, she was 190. So not only was she able to lose some weight with the surgery, but she's able to continue to drop it down gradually over time. So I think that's basically the presentation of the case. This is a graph of the weights. I was having a little trouble doing this PowerPoint graph here. For some reason, these parts wouldn't label, but it's basically spring, fall, spring, fall, spring, fall. And so you just see the curve. She maxes out, and then she has the surgery, and she just starts coming down. So what I think that this case really illustrates is how difficult it can be to manage weight, and how much weight or increasing weight and just kind of girth can make it very difficult for a person with spinal cord injury to perform ADLs and other activities like driving. So I want to, that was the case, and her story got me really, back to the literature, trying to see what was out there, because as I said before, none of this was in my training and residency, and I'm interested to see. I know there's some residents here today. I wonder if it's now part of residency training, and I'm going to talk about some ideas about management and all, but I'd love to hear other people's thoughts and experiences on this subject. So the first thing I looked at was BMI. So for people who are not familiar with BMI, It's a number that's calculated from a person's height and weight, and it's an indicator of body fatness. So what it is you use, it's kilograms over meters squared is the formula. So it's not in inches and feet and pounds. But if anyone wanted to go to Google and put in BMI, you can find a BMI calculator and find your own BMI. You can put in feet, inches, pounds. You don't have to be metric to do it. It does it for you. It's used by physicians and dietitians to assess a person's risk for developing obesity-related disease. And there's some guidelines for, where people should fall in here. And if you're 18.5 to 24.9, you're considered normal. 25 to 29.9 is overweight, and over 30 for a BMI is obese. So in the journal Spinal Cord, Buchholz says that in the spinal cord injury population, BMI is an insensitive marker of obesity. This may be due to potential measurement error and to the inability of BMI to distinguish between fat and fat-free mass and to measure body fat distribution. So Jones, in the Archives of PM&R, compared 19 men with spinal cord injury and 19 controls, people without spinal cord injury. They looked at BMI. They looked at dual energy X-ray absorptiometry. Now that is essentially a radiology study that can distinguish between fat and lean tissue. And they found that the groups were similar with regards to BMI. But the people with spinal cord injury had a lower lean tissue mass, more fat mass, and a higher body fat percentage. So you're talking about two groups of people with BMIs that are similar. So you plug in height and weight, you get the same number, but the distribution is very different. There's more, there's less lean tissue, and lean tissue is the tissue that has more metabolic activity to burn energy. So Cosina did a study and published in Sports Medicine in '97, where they showed that comparing able-bodied men and women to active and sedentary SCI patients, the people with SCI on average had more body fat. McDonald, in the Journal of Spinal Cord Medicine, did a study with 60 patients who were aged 10 to 21. So now we're talking about children and adolescents. And these people had traumatic spinal cord injury, and they were compared to a group that were age, gender, and BMI matched. And what they found, they used that DXA test and saw the lean tissue versus the fat tissue, et cetera. And they found that the body fat percentage in the paraplegic group was 31.4%, tetraplegic 25.7%, and controls was 22.9%. And then in lean tissue, you see that the paraplegics and tetraplegics have less lean tissue as well. And not to get into all these ratios and all, but basically what the McDonald study shows is that a thing that they showed in the Jones study of adults is also true of kids and adolescents. So Weaver did a study, and they looked at about 8,000 veterans with spinal cord injury, and they used the standard BMI measurements. And then they also adjusted BMI, because there's some people that write in this field who say that in spinal cord injury, you really should be taking the guidelines and just dropping them down about 10%, and that would be a more accurate measure. And what they found was that the overweight and obese go up a lot, especially obese. With the standard measurement, they found 20% of the patients to be obese. With the adjusted measurement, they got 31%. So it's BMI underestimates the obesity in spinal cord injury. And I think that going back to my patient, CCA, you know, she had a BMI of 35 when they denied her for the lap band because the cutoff was 40. But I think that, you know, they weren't thinking about this information here about body fat distribution, et cetera. So, you know, lean tissue and fat tissue have different metabolic rates, and this translates into the fact that people with spinal cord injury have a lower basal metabolic rate, especially in people with high tetraplegia. And in Monroe's study, they looked at 10 male spinal cord injured patients and compared them to 59 age-matched controls. And they looked at the 24-hour energy expenditure, which they found to be lower in individuals with spinal cord injury. They found spontaneous physical activity was lower, metabolic rate was lower, as was the thermic effect of food, which is basically kind of the energy that's consumed just digesting your food. So Buchholz and Panchars state that measured resting metabolic rate is 14 to 27% lower in persons with spinal cord injury, and it could be due to decreased fat-free mass and decreased sympathetic nervous system activity. So Maki et al. Published a study where they looked at anthropometric measures, which is just kind of taking a tape measure around the abdomen and looking at the circumference. They also looked at the BMI, the body fat percentage, and the waist to height ratio. And they found that of all those different things that they measured, that the abdominal circumference was the most closely associated with lipid profile. So one of the concerns with obesity is abnormal lipids, so total cholesterol, LDL cholesterol being high, HDL or the good cholesterol being low, and you know, what's been found in some other studies is that HDL is lower in people with spinal cord injury, and what was found in this Maki study is that the bigger the abdominal girth or abdominal circumference, the lower the HDL. Edwards did a study and published it in the American Journal of Clinical Nutrition. They looked at 15 subjects with spinal cord injury and 16 controls. And what they did in this study was interesting. They did a CAT scan at the L4-5 level, so right across kind of the lower belly. And were able to look at, by CAT scan, they were able to look at the fat that is subcutaneous or right under the skin versus the fat that's deeper, which is called visceral fat, or here they're calling it VAT, visceral adipose tissue. And they also did a waist circumference at 3 levels. They did it right at the lowest rib and then at the iliac crest, kind of like the top of the hips, and then between. They found that the people with spinal cord injury had higher visceral adipose tissue and higher total adipose tissue. But what's interesting here is that the waist circumference at all 3 levels, whether they measured it here, here, or here, correlated with the visceral adipose tissue in both groups. Now, I don't know that that's, you know, earth-shattering to people that, you know, the bigger you are around the middle, the more fat may be there. But I think what they were able to show by CAT scan was that it correlated with the visceral or the deeper fat tissue. And it seems to me that waist circumference is probably a better measure than BMI, or using waist circumference with adjusted BMI may be a more accurate measurement. So, you know, what do you do for weight management anyway? You know, what does anybody do? And it is a very challenging problem, as everybody knows. We have an obesity epidemic in this country and in much of the developing world. And really what we have at our disposal is education about the importance of weight management for health. We have a diet, and there's as many types of diets as there are dietitians or people who can write a book, you know, so it's hard to know what's the best diet. There's exercise and there's surgery. And so what we don't really know in the spinal cord injury population is, you know, what is the best diet? What is the best exercise program? And we don't really know much about the surgical options because there really haven't been many examples of it or studies of it. So Chen published a paper in Spinal Cord in 2006 where they looked at 16 people with spinal cord injury who were overweight or obese, and they put them in a 12-week weight management program that included time-calorie displacement diet. So that is, as best I can understand that diet, it is this idea that calorie dense foods should be replaced by foods that are less dense in calorie. So, you know, it could take you the same amount of time maybe to eat a Snickers bar as an apple, but you would get a lot more calories from a Snickers bar. So what you're trying to do is displace things with, you know, less calorie dense foods. So it turns out to be more fruits, more vegetables, more whole grains. It's a story that we've heard many times. But so this is the diet that they used. And they used exercise, although they didn't define it very closely what the exercise program was. So they didn't say if this was resistance training or aerobic exercise. It was basically just advising people to exercise 30 minutes a day. And they did a group education and support program which met every week, and there was a different topic discussed each week about diet, health, exercise, etc. And they found that in these people who were fairly removed from their injury, I think the average was like 9-10 years post-injury, these people were able to lose 3.5 kilograms, which is something like 7 or 8 pounds, by week 12. And they were mostly able to keep it off by week 24. So you can see the number went down a little bit. But this is at least a beginning. It's an idea about a program in which people can really lose some weight, and they were able to show that. They felt in their paper that the group education and support part was possibly the most important part, and that's not surprising. I think that is what really helps to keep people on track, checking in weekly. There's a new study that's being put together in Canada by Martin Guinness, and this was published in Spinal Cord this year. It's called the Study of Health and Activity in People with Spinal Cord Injury, or SHAPE, SCI. Their goal is to establish evidence-based physical activity guidelines for individuals with SCI. You know, at this time, I am not aware of guidelines that say, you know, what is the best kind of exercise to maintain fitness and appropriate weight for people with SCI. And I was able to come across this paper by Ali Dean in obesity surgery, in which they reported the first case of an individual with paraplegia who had a Roux-en-Y gastric bypass. This was done at the Cleveland Clinic. And I contacted Dr. Aladdin and just asked if there was any report of others who've had this surgery, especially were there any tetraplegics who had this surgery. And his response was that this is the only person he's aware of that's ever had this surgery. And this was a VA patient, and he said it took quite a bit to get the VA to agree to this, but in the case report, you can see that there was a significant improvement in this gentleman's function after this surgery. So it's a beginning, and I think in closing tonight, I just want to put out some recommendations, but I really think the Q&A could be interesting to share ideas and experiences. Rehab professionals need to incorporate teaching about weight management, including prevention, in the rehab process for individuals with SCI. So that should start at the acute rehab level and work, and be incorporated into the office visits as well. It's a lot easier to maintain weight than it is to lose it once you've put it on. And more research is needed on the best diets to maintain weight in SCI. More emphasis on and access to exercise. I think that that's something that's very difficult for people that have spinal cord injury who live maybe in Boston it's not as much of a problem, but in other parts of the country where you're not as close to big cities and lots of health clubs and all, it's very hard to find good, safe places to exercise. Research is needed on the appropriate use of surgical interventions. Is it even safe to do? We're not sure. But I think that the evidence is there in the general population, and I think that there's a need there for some people with spinal cord injury. And I think education of insurers is really important as well. I don't know that my patient's story would be different if they would have approved the scale for the Hoyer lift, but it would have helped her to keep tabs on her weight right up front from day one. But that's not just about getting a scale for a Hoyer lift. It's also about getting approval for ongoing therapies for people, in the quote maintenance phase. People needing health club memberships or access to aquatic therapy, and how this, can keep people more functional, independent, healthier. It's good for the people, and it should, save the insurers money as well. So, thank you for your attention, and that's really the end of the talk tonight. Thank you.
I'd like to know
Yes.
if one has a tremendous amount of muscle spasm, is that incorporated as exercise involuntarily?
Is that considered exercise?
Involuntary?
Involuntary. No, it's a very good question. I don't consider it to be exercise in the sense of what I'm talking about here, where the sort of exercise that may help to maintain weight. It does tend to maintain muscle, preserve muscle size, but not, I don't think it's the kind of exercise that burns enough calories to, offset your intake.
Okay.
Oh, yes.
I want to just proclaim things that have happened in my life. By doing what I was told to do by a pastor, by a naturopath, before I had the onset of my disease. I'm doing the same thing now, but it's not working as well. The thing I did was called proper food combining diet. And that's almost a vegan diet, if you will. But you eat watermelon when you eat watermelon. You eat cantaloupe when you eat cantaloupe. You eat honeydew when you eat honeydew. You don't eat them together. They don't digest together properly. So you separate what you do. You don't have potatoes and meat at night. You have meat and vegetables. No meat and potatoes. You don't have hamburgers with buns. You have a hamburger and a vegetable. It will digest. If you read the book, it makes sense. Take it from one who did it. I was 158 pounds upon graduation from high school. I was again 158 pounds 20 years later. I was again 158 pounds 15 years later. Then this hit, and it doesn't work anymore. I don't know what to do. And then the other thing I used was a 3-foot wide trampoline. It was with the Dr. S. Samuel W. West rehab, if you call it. It was a system of standing on the pad, going up and down for 30 seconds the first day, a minute the next day, a minute and a half the next day, until you're up to 30 minutes. After 30 minutes, then you can jump on the trampoline. And it worked. I was up, I was doing this stuff, sitting on the stupid trampoline, bouncing on it with my butt, and it got me to stand up and bounce on it for that little extra I needed. It took me a month to get through it, so I was walking. 2 months later, I was walking with a cane, and I never kept it up because I just assumed I was done with it. And you can't assume you're done once you start something. You always go on the presumption if you did it once and you needed it, you better do it the rest of your life. And just do it. It works. I know it works. I just don't know how to get up, standing on the trampoline, secure on the trampoline, and go up and down again. And I want to get there. I'm almost there. I'm standing up, holding on to the rail at the toilet, which is better than it was. So that's improved in 6 months' time, 7 months' time. And if I can do that, I can put that trampoline down, possibly stand on it and hold that bar and do the exercise that way. I'll figure something out to do it. I'm destined and determined to do it. But those are the things that have worked for me, that have worked for others, and that I'm just sharing the experiences I've had. And it did help other people that I worked on. Where they felt pain, I took it from them as I did for myself. Where they had problems with their swelling in their feet, I took it from them by standing on the trampoline, going up and down. It reduced the size in their feet from the swelling. It removed discoloration in their feet from the swelling. It did a plethora of things for people, and it does work. It's up to everybody in here to do it. I can't diagnose anybody, but if you're willing to take a chance and you're willing to look for improvement, those are the best tools I have that I know about. Outside of that, you're on your own. Sorry.
Thank you.
All right.
Thanks for sharing your experience.
You're entirely welcome.
Yes?
Yeah, I work with a group of people of higher level of spinal cord injury, and I've been watching people for the last 15 years who started out in rehab with, well, more of a problem of putting on weight. And so I don't think in rehab a lot of focus is on weight maintenance to lose. It's more about gaining and keeping your protein intake up. But what I'm finding is people are gaining weight. They don't fit in their chairs. And insurances are more willing to pay for a new power wheelchair to fit somebody's increased width than the rehab they need. You know, and I don't know what to tell people to do for exercise, because it takes some pretty expensive technology to really do any effective exercise. So if you have any suggestions, anybody, I'd like to hear it.
Yeah, I agree with you. I think the first point was the difficulty in maintaining weight, like putting it back on after injury, which is seen in the acute phase. And interestingly, this lady, CCA, that I talked about tonight, when she left Health South, she was on a regular diet and also was advised to use Ensure with each meal. So, you know, they were trying to kind of beef her back up, but didn't really say what to do, you know, when to stop that, you know. And so that is, you know, when is it time to switch gears? And I think that it's very challenging to find, you know, exercise that everyone can do that's effective. And you know, I'm really, you know, I come here to share a story, but I'm by no means the expert. And I don't know if anybody out there, you know, in the audience has some, you know, exercise ideas or prescriptions that they think work for people with high tetraplegia. You know, I'd be interested.
I'd like to just share my story. I'm up here on the front.
Where
Over
are
here.
you? Oh, there you
Right here. I have a C5-6 spinal cord injury, chronic for 25 years, and starting in 2005, I was able to lose 50 pounds through diet and exercise. And what I did was I did very low-calorie diet, under 1,000 calories a day.
Yeah.
I did FES bike training, Nautilus training, and a wheelchair aerobics DVD 3 times a week. And like I said, I lost 50 pounds in the course of probably about 10 months, and I've kept it off the whole time, and I still go to the gym 3 times a week.
Yeah.
So I really think it is a combination of diet and exercise. And most of the people at the gym with me are tetraplegics, and they've all noticed a decrease in weight
Yeah,
in the
fantastic.
program. It was a program that you were involved in, Dr. Williams.
Now, did you notice when you were heavier that you had more difficulty doing things?
Yeah, I started the program because I went to the BMC lecture and I heard all the benefits of activity-based therapy.
Yeah.
So that's why I said I have to do something because I was losing function, specifically driving, and my spasticity was increasing. So I just made a goal to get active, and it really paid off.
It's a great story. So is there, Steve, do you have something that it's a program that people are doing? I'd like to hear that.
So I think what Kristen was talking about is the First 5 program at the Quincy YMCA. And the Quincy YMCA has done a wonderful job of investing in equipment that people who have paraplegia and quadriplegia are able to use. And they have given us a staff member who runs an exercise program there. I think it's 3 times a week, is it? It's 3 times a week in the evenings. And so this person is there to assist people onto the equipment. There's functional electrical stimulation biking, and there's adapted weightlifting equipment, and quite a bit of equipment, probably 10 pieces of equipment. And it has been a great program, and a lot of my patients have participated, and a lot of people have really lost weight, have improved their function, have increased their strength. So I think it is valuable for people who live, you know, close by and can get to the YMCA. It is a challenge, like you said, I think, to find health clubs that are accessible and that are willing to maybe devote a staff member to helping people who are disabled get onto the equipment, etc. But we've been very fortunate with the Quincy YMCA and with Sue Sheehy, who really started the program, and it was funded by the Travis Roy Foundation, which was wonderful.
Yeah, well, thank you. Yeah, that's exactly the sort of thing that, you know, that people need is a place where they can go and they have the appropriate equipment and it's safe and accessible. And you all are fortunate. Are you aware of any other places in the Boston area that have that kind of program?
So I don't know of any other place that has as an extensive a program, but Claudine was involved in working out with the YMCA so that our patients, when they were discharged from acute... So Claudine was instrumental in working out with the YMCA so that when our patients were discharged from acute rehab, they would qualify for low membership fees at the YMCA or for scholarship. And so there was an accessible Y, I think in Brighton, and in Boston, the one on Huntington Avenue near the MFA. And they both also had pools, I think, and did aquatic therapy programs as well. So that was, and I would say that if you don't live in Boston, Claudine and I often just kind of sit and think of these crazy ideas that we want to instrument, and we just call people and ask. And I'm shocked at how often they say yes. And so the Y was very open to that. And so, you could probably approach a YMCA in any of your towns and determine if they're accessible, and if they're accessible, if you can gain access. And also then, through the network of the National Spinal Cord Injury Association in either Massachusetts or New Hampshire, you might be able to find therapists who might be willing to volunteer time in the evening rotating to start a program at a YMCA.
I also your local gym. We have many people have told us they've just approached their gym and they have brought in equipment for people that are using wheelchairs. I know this, again, usually on the South Shore is just where people are telling us they've been, but they've brought in equipment, and it's usually like once the gym brings in one piece of equipment, they start building more of a following of people who have a disability who are coming into that gym regularly because now they know they have. So if you have a gym, just call them and ask them what they have for accessible equipment and if they're willing to bring any in for you.
And I would also say that just another gym that I know in the area has provided accessible equipment is the Dedham Racket and the Dedham Racket Club. Yeah, that's it. The Dedham, say that again? The Dedham Health and Racket Club, yes. They've been very receptive to, people with disabilities. I've had a lot of patients who have gone there as well.
Hi. I think a lot of the local health clubs, they don't get equipment because the equipment's so expensive. I think what we need to do more is have people with disabilities advocate for equipment. It should be something in the local gyms, and there should be some type of grants out there for the equipment. It's so needed. A lot of the gyms, speaking with a lot of the gym owners, they say the equipment's so expensive or they don't have the room. I think a lot of them, the owners are afraid of the liability as well. So we have to go out and educate the gym owners and talk to them more about where they can purchase the equipment, how to make their facility accessible. That's another thing. So.
And the other thing, Tony, is that, I think the Travis Roy Foundation is a perfect example. There are probably foundations similar to Travis's, and Travis's may be willing to help fund some equipment at local gyms. It's always worth putting in an application if there's somebody who could organize a program at one of these places. I'm sure that many of these small foundations around would be very interested in entertaining those applications.
Also, your independent living centers, is speaking with the people at the independent living centers to help you to advocate for the equipment. Dr. Williams knows I've been working on this for a very long time. At one point, I developed a business plan for an accessible facility in the Boston area. A lot of the accessible gyms are on the outskirts of Boston, and there's no transportation. So a lot of the inner city people do not have access other than the rehabs. So it's a big issue, and it would certainly help with preventive medicine. And since, people are in the hospital often, but if, you had access to fitness equipment and good nutrition, then, that would certainly cut down on the cost.
A week ago Monday, a group of fitness instructors from Metro Boston YMCAs held a teach-in at the Constitution Inn YMCA in Charlestown. And I did not attend, but a number of people from my MS support group did attend, and maybe some of them could tell you about the efficacy of that experience. A number of them are here. Rose, do you want to speak about it?
Yes. Okay, yes. So I went to the program that they had, and they were showing what happens. I have MS, so it's just like, disability, the spinal things. Anyways, they helped me to use the equipment at the YMCA. And yes, so there are things that can be done at the YMCA, and they were practicing on how to help people who need help. So that made it good. If you have someone there that can help you, if they know what you need, so you just have to speak up and tell them what you needed. And then I thought it was very nice. Yes.
Is this on?
Yeah.
My name is Brad. John and I work for a facility in Canton called Journey Forward, which works with spinal cord injuries with exercise-based type recovery. Our goal and mission is more on the recovery side, trying to maintain levels of recovery and increase recovery if possible. With a lot of the research is coming out that's saying that just doing certain activities like load-bearing, gait training, some of the things they're doing here at Boston Medical with locomotor training, with those things as well. So the issues that we've come into is, again, with this adaptive equipment, with the trained staff, everything's one-on-one, those things, it's expensive. And we're in the process of trying to lower the cost of our program and working to see if we can go insurance routes or if we could through fundraising and through all those aspects. It's difficult because I think the things that like the Quincy Y and those things that are doing an excellent job in trying to do it as most cost effective as possible. And with our program, we're trying to be as aggressive and offer the latest and the best possible types of recovery that are out there. However, to do that, it's extremely expensive. So trying to bridge the gap and see how they can make it possible. But back to the weight aspect is a lot of our clients will come in and either maintain what weight they're at, or they'll even start to lose weight based on the activities that they're doing, and working on those different everything from vibration training and the load bearing and everything.
Any other questions? Yes.
On your case study, did she, after her plastic surgery, start a more vigorous exercise routine?
No, she did not.
So do you attribute her slow weight loss following that surgery to like a decreased body fat to lean body mass ratio that maybe gave her an overall average better metabolic rate?
I think that may be the case, and she also did find this caloric intake that worked for her. I think it was something like 1,000 calories, 4 days a week, or so. Is what she was finding had worked. But at the point when she discovered that, she was already so behind the 8 ball with the weight that she couldn't make up any ground. And I think that's what happened. because she's as active as she was before. She still does a stim bike, and she still does aquatic therapy. You know, she hasn't increased her level of activity.
So, well, what it makes me think about is that able-bodied people will go to a plastic surgeon in search of some what do you call it? Liposuction, and they can't have it as if they have some weight to lose.
If they have what?
They can use it maybe like as a body sculpting thing to get rid of that last little pocket of stubborn fat, and it kind of makes me wonder, gee, I wonder if they just take out some of the fat to start with, it can start the ball rolling on a more automatic weight loss program. And boy, if somebody wants to do a study on that, I'll be in your control group that'll go for the liposuction before losing a bunch of weight. Oh, yeah, see, sign the two of us up, we're in. That's it, I guess.
Any other questions this evening? No? All right. Well, thank you for your attention. It was a lot of fun.
Thank you so much for coming.
Yes. Thank you.